بسم الله الرحمن الرحيم. السلام عليكم. اليوم راح نستكمل سلسلة محاضرات طلاب الطب السنة الخامسة مساق العيون في الجامعة الهاشمية. اليوم محاضرة راح تكون عن Red Eye. Red Eye قسمناها قسمين: Painless Red Eye and Painful Red Eye. فاليوم راح نحكي عن Painless Red Eye. First of all, خلينا نحكي إنه once we have a patient with red eye, it's very important to perform a systematic, comprehensive exam to determine the involved ocular structure. Generally speaking, red eye might be caused by infection, could be either viral, bacterial infection, or inflammatory cause. Allergic or autoimmune disorder, for example, affecting certain structure of the eye. We should not forget also that acute elevation in the intraocular pressure, the case that is known as acute angle closure glaucoma, is a well-known cause of red eye, but it is usually painful. Red eye may be due to abnormality of a number of ocular structures, including adnexa. Adnexa, it's a term that is used to describe the external structures around the eye, including the eyelids, the lacrimal system, the lacrimal apparatus, the orbit, etc. So adnexa can be involved in inflammatory disorders. Lacrimal system also can be involved in inflammatory or infectious causes. All orbital diseases might cause also red eye. Or the red eye might be related to the globe itself. Globe means the eye. Whenever we use the word globe, that means we mean the eye itself. And that might be affecting the conjunctiva or sclera, cornea, uveal tract in the form of uveitis or glaucoma. It's very important to take good history and perform physical examination to localize the abnormality and determine the pathology. For example, the history might help us in characterizing the disease of the patient. We should ask about the symptoms, the duration, whether it's acute, hours, days, or weeks, whether it's unilateral or bilateral, onset of symptoms, precipitating event, might be traumatic or related to contact use, previous episodes, previously used treatment and duration of that treatment. We should not forget what we call the general danger symptoms. هاي symptoms لما نسمعها من المريض والمريض يحكيها it's dangerous, it's serious, يعني it's visually significant. High danger symptoms include decreased vision, severe ocular pain, colored halos, and sometimes we may add photophobia. فهاي الأعراض لما نسمعها والمريض يحكيها دليل أنه في عنده مشكلة serious problem threatening his vision على long term. إيش ممكن الأشياء اللي إذا سمعناها بإيش ممكن تخلينا نفكر؟ For example, إذا سمعنا مريض بيشكي من itching, seasonal exacerbation of its redness with associated rhinitis, we should think of allergic causes. Burning sensation, foreign body sensation, tearing, we might think of blepharitis or dry eye syndrome. Localized lid tenderness points to the presence of hordeolum and chalazion, and etc. Each symptom might suggest a specific diagnosis, so we should ask about those specific symptoms whenever we have a patient with red eye. Then we proceed with direct ocular examination, recording the visual acuity for distance, near, with correction and without correction. We should also examine the pupils for shape and symmetry There are certain cases of red eye, such as uveitis and acute angle closure glaucoma. Pupil might be asymmetrical. There might be posterior synechiae in patients with uveitis that make the shape of the pupil irregular. We should check the reactivity and look specifically for relative afferent pupillary defect. External examination is very important. We should look at the eye and see the distribution of the redness, whether it is diffuse or palpebral, fornicial, peribulbar. Diffuse means all the conjunctiva is diffusely injected or red. Fornicial, that means the fornix, which is the junction between the palpebral conjunctiva and the bulbar conjunctiva, is injected. Palpebral means the conjunctiva that is covering the eyelid from or lining the eyelid from inside. Perilimbal or ciliary injection, it's the localized injection around the limbus and sometimes called the ciliary flush, and it signifies irritation of the anterior segment and the ciliary body. In cases, example for those cases, keratitis, uveitis, acute angle closure. We should also observe for eyelid swelling, localized swelling or diffuse swelling, if it is also associated with tenderness or not. We should look for any area of tenderness and localize it. For example, if it is related to the dacro, to the lacrimal gland, it's called dacroadenitis. If it's related to the lacrimal sac, it's called dacrocystitis. Then we move to slit lamp examination. It's very important. We look at the lid margin, looking for blepharitis, then assessing the conjunctiva and conjunctival reaction. If there's follicles or papillae, we'll talk later about follicles and papillae. We should examine the cornea in details, looking for the clarity of the cornea, keratic precipitates, corneal defects, foreign bodies, etc. Anterior chamber, it's very important to assess for the presence of anterior chamber inflammation. Lens, iris, intraocular pressure, all are important part of slit lamp examination in the management of red. Now we'll talk briefly about the different types of or different causes of painless red eye. We'll start with talking about bacterial conjunctivitis. Patients with bacterial conjunctivitis, they're present with palpebral or diffuse redness, purulent discharge. المريض بيجي بيحكي انه عيونه الصبح لما يصحى من النوم بيكونوا ملزقين ببعض وعليهم افرازات بتكون اصفر على اخضر، وهاي بتعطينا فكره انه this is purulent discharge. بالاكزامينيشن راح نشوف في عندنا papillae. The eyelids might be edematous in addition to the injection of the conjunctiva. هاي الصورة بتفرجينا example of palpebral and fornicial conjunctival injection. شوفوا كيف eyelids عليهم sticky greenish sticky material. بدنا ننتبه كمان هون انه نطلع على الكورنيا، نطلع على بيوبل، في عندنا راوند بيوبل، في عندنا كلير كورنيا. هذا الليمبس، هذا بنسميه الليمبس. ما في عندنا انجكشن اراوند ذا ليمبس، فعشان هيك ما في عندنا سيلياري فلاش. الانجكشن معظمه على الفورنكس and the palpebral conjunctiva مع discharge. فهذا يعني tells us that the issue is conjunctival problem rather than anterior segment, deep anterior segment problem. The bacterial conjunctivitis commonly caused by Staphylococcus coagulase staph, Streptococcus, Haemophilus, and rarely Pseudomonas species. How do we treat it? Culture, not necessarily all the time. Most of the time we need to do warm compresses, cleaning the lids from of discharge, and using a topical antibiotic for 7 to 10 days in the form of drops and eye ointment. Sometimes it starts in one eye, then it moves to the other eye. The severity is variable between patients. Some patients, the disease will be mild. Some patients, it is very severe, and the patient is very much distressed by the redness and the discharge. Of course, it is contagious, so we usually instruct those patients to stick with good hygiene, cleaning their hands, don't share towels and other personal things with other members in the family. There is a specific type of bacterial conjunctivitis called hyperpurulent conjunctivitis, and this is conjunctivitis that affect the neonates, part of the what we call the ophthalmia neonatorum. It's caused by gonococcus species, and if not treated, it causes perforation of the cornea. So once we detect hyperpurulent conjunctivitis after birth, we need to treat with intensive intravenous antibiotics in addition to the topical treatment. And this is a picture of low resolution, but you can see the excessive amount of discharge coming out of this eye. What about viral conjunctivitis? Viral conjunctivitis patients usually present with similar complaint as the bacterial conjunctivitis: burning sensation, redness, some itching. The injection is also palpebral. Patient may give you history of upper respiratory tract infection or history of contact with a person who had similar condition. Signs of viral conjunctivitis include mucoid or watery discharge, conjunctival follicles, and I will show you in a second how the conjunctival follicles look like. Pre-auricular lymph nodes usually are palpable. Sometimes certain patients, they may form pseudomembranes on the conjunctiva. You should be able to differentiate pseudomembranes from true membranes. Pseudomembranes usually are exudative material, deposition on the surface of the palpebral conjunctiva. That exudative material can be peeled away from the conjunctiva and should be peeled as part of the treatment away from the conjunctiva, and usually it doesn't bleed. The true membranes, they form adhesions between the membrane and the underlying tissue, and usually it's difficult to peel, and if peeled, they will lead to bleeding. So viral conjunctivitis will form pseudomembranes rather than true membranes. And certain strains of viral conjunctivitis, specifically the adenoviral conjunctivitis, there might be, in addition to the conjunctivitis, involvement of the cornea in the form of keratopathy, and that will show as formation of subepithelial infiltration after 10 to 14 days from the onset of the viral conjunctivitis, and that might be a cause of discomfort and blurry vision for the patient. Viral conjunctivitis is highly contagious, can occur in epidemics. Adenovirus is the commonest cause. One eye might be involved at the beginning, then the second eye might be involved later. Treatment is supportive. There is no specific treatment for the virus. We usually give the patient artificial tears, cold compresses. In severe cases, patients who present with severe redness and injection, we might use mild steroids to reduce the intensity of the symptoms. It takes about a couple of weeks until the patient start to feel some improvement. This picture shows you how viral conjunctivitis may present. You can see the puffy eyelids in both eyes, the watery, probably some mucoid discharge that is apparent. Both conjunctiva are injected. This is the palpebral conjunctival injection with the follicles. These are the follicles. They are dome-shaped elevations. In viral conjunctivitis, usually they appear in the lower palpebral conjunctiva. They are hypertrophy of the lymphoid tissue that is present in the conjunctiva. They have dome-shaped smooth surface. Usually we compare it to the papillary reaction. I will show you later how the papillary reaction looks like and how it's different from the follicles. This is a picture that shows the corneal involvement in certain cases of adenoviral conjunctivitis. These are the subepithelial infiltration. This picture of course shows an extensive form. They present in different degrees. Some of them is mild with a few lesions. Some of them is such an extensive that affects the vision of the patient. Now we move to the chlamydial conjunctivitis. Chlamydial conjunctivitis, it's in two main forms. First, the adult chlamydial keratoconjunctivitis, and it's considered a sexually transmitted disease caused by Chlamydia trachomatis serotypes D to K. Patients with chlamydial conjunctivitis usually young, and at least 50% of them have concomitant genital infection. Transmission is by autoinoculation from genital secretions, and sometimes or rarely from eye-to-eye spread. Usually they present with subacute unilateral or bilateral mucopurulent discharge. Redness is not conjunctivitis usually may persist for months in those cases. On examination, there is the edematous conjunctiva, mucopurulent discharge, papillary reaction, and follicular reaction. But here, the follicular reaction may appear in the upper tarsal conjunctiva, in contrast to adenoviral conjunctivitis, where the follicular reaction only in the lower palpebral conjunctiva. Of course, in addition to non-tender lymph adenopathy. Corneal involvement is uncommon, and in long-standing cases there might be conjunctival scarring. This is an example of follicular reaction in the lower palpebral conjunctiva in patients with adult inclusion conjunctivitis or chlamydial conjunctivitis. Treatment is with tetracycline ointment. 4 times daily for 6 weeks. We add to that the systemic therapy to the systemic infection by doxycycline, tetracycline, or erythromycin. Chlamydia also can cause conjunctivitis in neonates, and it's another cause of ophthalmia neonatorum, called neonatal chlamydial conjunctivitis. It's the most common cause of neonatal conjunctivitis. It might be associated with systemic chlamydial infection in the form of otitis, rhinitis, and pneumonitis. And because the infection is transmitted from the mother during delivery, it's very important to test for both parents for the evidence of genital chlamydial infection. They present usually between the 5th and the 19th day after birth. Signs include papillary conjunctivitis with mucopurulent discharge, and usually we treat with topical tetracycline or with systemic treatment for the systemic chlamydial infection. This is a neonate with ophthalmia neonatorum. It shows puffy eyelids, sticky eyelids also with the discharge. The most common cause of such condition is chlamydial conjunctivitis. Other causes, as we talked before, the gonorrhea, herpes, and herpes simplex conjunctivitis. Now we come to a different group of red eye in the allergic group. So allergic conjunctivitis is a major cause of redness, of eye redness. It is present by the most important symptom is itching. In addition to the redness, which might be in different forms, perilimbal, bulbar, palpebral, and this itching and redness might be seasonal or perennial for the whole year. There might be a history of atopy and other atopic disorders or history of rhinitis. On examination, there might be chemosis. Chemosis means conjunctival edema or papillary reaction. The most important sign in the conjunctivitis of allergic cause is the papillary reaction, in addition to mucus. In certain cases, such as the vernal catarrh, there might be limbal thickening with white deposits. This is diffuse conjunctival injection with whitish sticky discharge, suggestive of mucus origin. We treat the allergic conjunctivitis with cold compresses, artificial tears, but the most important is topical mast cell stabilizers. In certain severe conditions, we may use topical steroids or topical antihistamines, vasoconstrictors. This is a picture showing upper palpebral papillary reaction. These are the papillary. They are elevations in the conjunctival tissue. Usually, they are on the upper tarsal conjunctiva. And why they appear? They represent conjunctival edema, but the anatomy in the upper tarsal conjunctiva is different from the lower tarsal conjunctiva. The upper tarsal conjunctiva is adherent to the underlying tarsus by fibrous septi. Different fibrous septi. So when the upper tarsal conjunctiva become swollen, the area between the fibrous septi is protrudes forward as a reaction to the edema, and that will show as the papillary reaction. So these papillae are just areas of conjunctiva that are edematous, but the conjunctiva is not diffusely swollen because of those fibrous septi. Now we'll just give you a brief description of certain miscellaneous causes of red eye, degenerative causes of the conjunctiva causing red eye. First one is pinguiculum, and the plural is pinguicula. It is a change in the conjunctiva due to different environmental factors, including wind, sun exposure, and it is characterized by increasing the vascularity. It's confined to the conjunctival tissue, doesn't involve the cornea, and usually it gets inflamed sometimes as a response to irritants in the environment, such as smoke, fumes, dryness. Treatment is supportive. Rarely we need to do surgery. This is an example of pinguicula. It's very common. Roughly, it is triangular in shape with the base at the limbus and the apex is away from the cornea. Does not encroach in the cornea. The pinguicula itself is avascular, but it is surrounded by some vascularity. Unless its size is large enough to warrant surgery, usually we don't do surgery for those lesions. The other lesion is the pterygium, and the plural is pterygia. It's a fleshy, elastotic degeneration of the conjunctiva. Usually the lesion is also triangular in shape, but the base is at the limbus and the apex is towards the cornea. It tends to encroach in the cornea, causing irregular astigmatism, affecting vision, and sometimes it may reach the center of the cornea, affecting, obscuring the visual axis. Sometimes the pterygium might get inflamed secondary to different environmental stimuli. Cosmetically might be ugly, so we need to do surgery in certain cases. If it starts to affect the vision or cosmetically unacceptable, we do surgery by excision of this lesion and doing graft, conjunctival graft. If the pterygium is small and not causing any disfigurement, usually we treat the patient with anti-artificial tears, mild steroids if it gets inflamed, etc. And we ask the patient to wear sunglasses and avoid exposure to dust and environmental irritants. Subconjunctival hemorrhage is another cause of painless red eye. It is blood beneath the conjunctiva. Usually, as I told you, it's not painful, and the patient usually has normal vision. It might be related to trauma or spontaneous. We'll talk about it when we talk about ocular trauma. If it's traumatic, then those cases should be examined thoroughly to rule out ocular injury. It may occur spontaneously after coughing, sneezing, or straining. Most of the time, it resolves within 1 to 2 weeks. Rarely we need to do blood workout for the coagulation system. We do that if it is recurrent. But otherwise, usually there's no treatment, no further investigation is needed. So this is an example of subconjunctival hemorrhage. It's blood under the conjunctiva. Thank you very much.